And so finally, tell me your thoughts on that late-breaking abstract, which went over the final overall survival for the phase 3 TALAPRO-2 trial, which combined talazoparib plus enzalutamide as the first-line treatment in unselected patients with metastatic castrate-resistant prostate cancer.
So we've been hearing a lot about PARP inhibitors in the last few years. And so this phase 3 TALAPRO-2 study showed RPFS and OS benefit in that quote unquote all-comer population who received this combo regimen. There are a few caveats. So it's not reflective of the current standard of care for metastatic castrate-sensitive prostate cancer because only 5 to 6% of patients got in ARPI, so things like abiraterone and enzalutamide in the castrate-sensitive setting, and only 21% got docetaxel in that setting also. So we know that the standard of care is that doublet with ARPI in the castrate-sensitive setting. We know that we have the triplet regimens now with chemotherapy, so we would expect in 2025 that way more patients than that would be getting those agents in the castrate-sensitive setting.
Yeah.
And in this trial, 21% of patients had HRR mutations. Most prevalent were CDK12, BRCA2, and ATM. There was an additional poster by Dr. Karine that showed that the greatest benefit was in those patients with BRCA2 mutations, which we know from prior trials is the same. A lot of the benefit is driven by the patients that have BRCA2 mutations. And as Dr. Tanya Dorf described in her discussion, a prior FDA analysis showed that the impact of PARP inhibitors is greater in BRCA, CDK12, and the overall response rate was negative in those with CHEK2 and only 7% in those with ATM. And those mutations are included in that HRR group. So I think it's still important to note that the response is not the same for every mutation. And then there is toxicity with this regimen, financial toxicity, hematologic toxicity. And despite most patients having an ECOG of 0 to 1 on this trial, only 30 to 50% received subsequent therapy, including only 3.7% receiving a PARP inhibitor in the placebo group. So I think, this is exciting data, but it will be interesting to see a little bit more detail on the HRR negative subgroup specifically, and also to consider differences in that BRCA negative subgroup.
Yeah, definitely. So still some questions to be answered, hopefully in the next year, few years of our GU conferences. So Karine, as always, thank you so much for presenting, for going to GU ASCO, for really condensing a lot of these high yield abstracts for us in a very short review. So thank you so much. This was a lot jam-packed in there, but I think you covered a lot of the key high points for GU ASCO of 2025.